All right. Good afternoon, everyone. My name is Charlie Hamadani. I'm the Community Relations Specialist here at Family Health Centers of San Diego. And it's my pleasure to welcome everybody to our Spirit of the Barrio webinar. As we said last year, it's difficult to envision our traditional Spirit of the Barrio luncheon without the normal gathering of friends and colleagues, the tents and the music, and of course the tamales. But still, I'd like to thank you for joining us today as we dive into an update of the COVID-19 pandemic and specifically to address the Delta variant with Dr. Christian Ramers. As a reminder, this webinar will be recorded and it's going to be made available via our website early next week. I'll be sending out an email to attendees with a link so that you can view this later on and share it with friends and colleagues as you'd like. I'd like to ask all guests to please stay muted, but I encourage you to submit your questions into the chat and we will do our best to answer them as time permits. First, I'd like to start off by thanking our amazing family of Spirit of the Barrio sponsors. Without the generosity of these partners, today's event and the pandemic response efforts that Family Health Centers of San Diego has carried out since the beginning of the pandemic would not be possible. I'd like to encourage everybody to support these organizations, especially during these really challenging times. And with that, first, I'd like to introduce our Corazon level sponsors, Port of San Diego, Rancho Mesa Insurance Services, US Bank, Cox Communications, Community Health Group, Medical Center Pharmacy. Thank you all very much for your support. I appreciate it. Next, I want to introduce our Adelante sponsors. These include Scripps Health and AO Reed & Co. Thank you both very much. Next, I'd like to introduce our Fiesta Grande level sponsors. Our benefactor level sponsors. And finally, our patron level sponsors. I'd like to thank our sponsors again one more time. We sincerely appreciate your help and the investment that you have given into the community. Thank you for caring for San Diego. And as with the support of our corporate partners, we need you as well. If you're able and interested in assisting Family Health Centers of San Diego with our mission of providing care to those most disadvantaged communities, you can go to fhcsd.org/donate and support us. So we're going to get right into it. I'd like to introduce Dr. Christian Ramers. Dr. Ramers is a leading infectious disease specialist with over 20 years of experience. At Family Health Centers of San Diego, Dr. Ramers serves as the medical director of the Laura Rodriguez Research Institute. He is the chief of population health, and he's the designated institutional official of the Graduate Medical Education Program. In short, Dr. Ramers is an internationally renowned infectious disease expert with decades of experience and has been on the front lines of the pandemic, not only treating patients and saving lives, but he's also been studying how the virus has progressed since 2022. Dr. Ramers has so many qualifications and experience that I literally could not fit them on one slide. He's incredibly wonderful, and we appreciate having him here so much. And I'm going to hand it over to Dr. Ramers.
Thanks, Charlie. Can you hear me okay?
I can.
Okay, and then I think you're going to give me slide advancing privileges?
Yes. Just 1 second here.
Okay, sure. Well, with that introduction, this better be a good talk. Feel a little bit humbled to be here, and thank you all for joining. I can share my screen if that would work better, Charlie?
Yes, please do.
Okay, let's do that. Okay, I'll get up to the front there and we will go to that. There we are. Okay. All right. So I'm going to try to get through the slides relatively quickly so that we have time for Q&A. And thank you to those of you that submitted questions. You can feel free to do more in the chat. I can't really see it from my view right here, but Charlie will help moderate that when we get done with the slides. I wanted to just focus in on transmission of SARS-CoV-2, the virus that causes COVID-19, because the rules have kind of changed in the era of the Delta variant. I'll buzz through very quickly a lot of graphics to show you just what's happening globally and locally with the epidemiology. And then I'll get into some specifics about what a variant actually is. And then the question on everybody's mind is, will the vaccines continue to protect us from the variants? So starting with transmission, this is an article that was published in Science Magazine, which is a really nice review of all the studies that have been done to date about transmission of not just SARS-CoV-2 or COVID-19, but other respiratory viruses as well. And I think there's been a lot of debate among scientists about what's more important in terms of transmission. Is it the droplets that come out of people's mouths and just fall right away to the ground, or is it aerosols? And if it's aerosols, that would mean really kind of different things to how we think about preventing COVID-19. The article doesn't really answer the question of which is more important, except it does say that both are probably ways that transmission occurs. And it just has to do with the size of the particle. What happens with these larger droplets, these are the kind of things that if you go to the theater and you see a very exuberant actor, speaking very loudly, you can actually see those droplets, and they tend to fall down within about 6 feet. 2 meters is really what the original guidance was. But there's increasing recognition that aerosols, or much, much smaller particles, can actually go a lot further and can even hang in the air for quite a while. And we certainly have other examples of other diseases, such as measles and tuberculosis, that are primarily spread through aerosols, these very, very, very tiny droplets. And it means different things for how we think about preventing those diseases. Someone asked in the submitted questions, really, why do masks work for this, and how do masks work? And really, masks are what we need to block from somebody who is sick with COVID-19, whether they have symptoms or not, block these droplets, which, even though they can be very different sizes, all will have some degree of virus inside of them. So the mask, of course, is not blocking the air. Air molecules are much, much, much smaller than these droplets. It just needs to drop the droplets and the aerosols from coming out of the infected person's mouth. And then if you're wearing a mask, it also can help protect you by blocking them from getting into your lungs. Now, I pulled a couple of just graphs here. I know this is a little bit sciencey and wonky, but it's important. The diameter of the aerosol, or the diameter of the droplet, is directly proportional to how long it stays in the air. And when you get to these really, really small ones over here on the left-hand side, they can stay in the air for over 10 hours. And when you get bigger ones that are much, much bigger, they, of course, drop right away. And I just I pulled another little part of the paper here, 3 examples of a 100 micron, relatively large droplet. If it's dropped from 1.5 meters in the air, it'll fall within 5 seconds. A 5 micron, 30 minutes, it'll hang in the air there. And then a 1 micron particle, the smallest little aerosol, can stay in the air for 12 hours. So this, to me, is why some people get infected and they don't know about being out around anybody sick. And we've seen several studies of documenting people just sitting on the other side of the restaurant from someone who had COVID-19 and getting sick as well. And this actually really reinforces everything we know about ventilation, about the utility of HEPA filters and air HVAC systems that have UV light in them, about opening the windows, and about how much safer it is to be outside. All of these points have been just hit home even more than ever because of Delta variant, because Delta variant is just so much more contagious. People that are sick with Delta have so much more virus, and it kind of reinforces all these general concepts. So to the question of whether masks work, masks do work. There have now been thousands of papers, scientific papers looking at this, and really the best situation is when everybody has a mask on, including those that are sick, including those that are not sick, and whether they're vaccinated or not. That's just going to give the smaller number of exposure to these particles. If everybody's without a mask, that's the maximum exposure, as you can see in this, this graphic here. Some of my colleagues have pointed out that they might have wanted to put goggles on there as well, because if you're really close to somebody with COVID, you can actually get infected through your eyes as well. And that's why we wear eye protection in the clinic. Just one study that I pulled to show the effectiveness of masks on a large population basis. This is data from New York City, where you can see several different policy interventions with social distancing, stay-at-home orders, and then face covering in the dark blue. And it was really the face covering, the universal masking mandate that really led to the big decline. This is back in the winter of last year. Whereas the general population in the US, there wasn't really any mask mandate, and the cases kind of just stayed as they are. Lots and lots of other experimental studies. When you go into a lab and you simulate people breathing and talking, the masks work. There's just really no 2 ways about it. Some masks work better than others. Of course, if I'm in clinic with 20 COVID patients that are coughing all over the place, I better have an N95 mask, as will all my staff. But for the general public, cloth masks work pretty well. Surgical masks work better. And then universal masking policies really work the best, because then you can kind of cover everybody up. I want to take a little detour to where I grew up in Marin County. This is a picture from Novato, because actually this outbreak that happened in a school in Novato kind of summarizes a whole lot of what I just said about ventilation and the Delta variant and why this is important. So this was reported in the CDC journal, the MMWR, and it's in a context in Marin County where in May of this last year, all the schools were open for in-person learning. They had 30,000 students going to over 100 public and private schools, and they had only 12 cases of transmission in schools because they really took school mitigation seriously, using all these overlapping safety measures of prevention of COVID transmission. This particular school was a K-8 private school that had 24 teachers and 200 students. Everybody in the school was vaccinated except for two of the staff, two of the teachers. And this entire outbreak was caused by one of the teachers. This teacher wore a mask in the classroom, however, took the mask down to read aloud periodically. It was very carefully documented what happened. So they called this partially masked. And this individual infected 12 out of the 24 students in their classroom. All of these kids were too young to be vaccinated, so it wasn't really testing vaccine. And the teacher who came to work actually sick, was symptomatic on May 19th, worked through this whole time, and then eventually tested positive on the 21st. Interestingly, the attack rate was very high in the first two rows of the classroom and a little bit lower in the back. 80% of the kids in the first two rows got infected and only 28% in the back rows. And overall, there were 27 cases in the outbreak, including kids from other classes, including their parents, 4 parents, and then including 3 that actually were fully vaccinated. Ultimately, almost all these people were symptomatic. And this is something that actually tipped the people looking into this outbreak off that something was different, because they had made it all the way through the whole last year with in-person learning using all these safety measures, and it seemed to work very, very well. They sequenced the virus from all 20, actually not all of them, 22 or so out of the 27 people, and it was 100% Delta variant. So this was kind of a warning shot for all of us to say, you know, outbreaks like this are going to happen even if we're quite careful with what we do. So on the right-hand side, you can just see the way this outbreak looked. Patient 0 is the index teacher that came in and then infected all these other kids. It also is a nice reminder of the timeline, that an exposure on day 0 really doesn't show up until day 5 to 10 with all the other infections that are caused. You can see this sort of jump into kids, even from different classrooms, because they were, of course, together at recess. And then the hashed boxes here are the adults that got infected from the kids. Here's a schematic of what the classroom looked like, and they documented this, that there was an air filter in the middle of the class. There were windows on the left side that were open, windows on the right side that were open, the door was left open, and yet you can see in this first 2 rows, 80% of the kids actually still did get infected. Here's a little different scheme just to look at it. The CDC made an infographic that overall 12 out of the 24 kids infected and overall 27 cases happened. So this is kind of a warning, and it was really the Delta variant making itself known, just so much more contagious, so much more infectious. And even if we do multiple things right, we have to get everything right to really prevent the spread of Delta. That involves masks really 100% of the time, getting vaccinated. Of course, none of these kids were eligible for vaccine. Staying home if you're sick, that's a pretty simple and easy one that wasn't followed in this case. And then the importance of testing to really catch these things early. I bring up this example because it really shows that the Delta variant sort of told us a lot of things that we thought we knew that were not necessarily true. A Delta just being so much more contagious. And then also the larger question about opening schools, it can be done safely, I think, if you have very close attention to all of our mechanisms that we have to prevent. But it also affects a lot more than just the kids. I don't have a final report from this outbreak, but I think most of these kids got sick, most got symptomatic, and then most recovered. And it's very rare for a child to go into the hospital with COVID-19, although it's happened 18,000 times in this country already, and there have been about 500 kids that have died from COVID-19. But most importantly to me is we had 4 adults that were involved. And just this week, I saw a patient in our monoclonal antibody infusion clinic, high school kid. He was 14, a little bit overweight, so he had a risk factor for having severe disease. But more importantly, he brought COVID-19 from his school, from his football team actually, into his home and infected his 90-year-old great-grandmother, who is still in the hospital right now, who has a very high chance of dying of COVID, probably a 30% risk, because she herself was not fully vaccinated either. So very, very controversial topic. I hope that story kind of brings in the Delta variant, the transmission, as well as the importance of using multiple measures to get through this together, and the fact that we all live in a big community and share the same air within our households and within our common spaces. Okay, I'm going to whip through these graphics just to give you a taste of what's going on in the rest of the world. This is the Johns Hopkins site showing that we've had probably 4.5 million deaths caused by COVID-19. There are still some people that try to pretend that this isn't real. Believe me, it's real. These other countries would not be reporting fake deaths because of COVID-19. Really devastating in a lot of places, especially those that have not really had great access to vaccines because they're still seeing high mortality rates. People that say that the vaccine campaign is experimental, really, we've given almost 6 billion vaccines in the world. We are getting intimately acquainted with the side effect rates. This is not really experimental anymore. FDA approval is really coming for one vaccine over the other. And we, of course, have FDA approval for the Pfizer vaccine. But really, this has been the largest vaccination campaign in the history of the world, which is quite remarkable. Here's the global snapshot by region. You can see that we've gone through several waves together. We've had places that have big surges like in India and so on, and now it's sort of just spread everywhere. On the right-hand side, you can just see the numbers here, about 4 million new cases in the last week worldwide, mostly declining though, and the comment from the WHO on this report was that this represents the first substantial decline in weekly cases in the last 2 months. So that's good news. The death rates is still sort of what I'd call a high plateau. It's that black line that you see across this graph here, about 65,000 people or 62,000 people dying per week. And then those are mainly driven by 5 countries, the US, the UK, India, Iran, and Turkey at this current moment. In the US, here's the map of cases. This actually looked a lot different just going back a month or so, maybe 2 months. But the Delta variant has just really resurged in the United States. The southeast of the US has been hit harder than anywhere else. But you can actually see the Mountain West and areas of Eastern Washington, Eastern Oregon, Nevada, and Wyoming are starting to show much higher rates. And so we're concerned that things are just going to get pushed out in more rural areas. As of a couple of days ago, this is from September 14th, we're seeing close to 2,000 deaths a day in the United States and about 150,000 cases per day, and nearly 100,000 people that are hospitalized. So really surprising to many of us that we're in this situation that we are now. And I'll show you many slides later on that this is by and large, especially the hospitalizations and deaths, unvaccinated people. And that's why you hear the phrase a pandemic of the unvaccinated right now. Here are the curves of new cases on the top left, hospitalizations in the middle, and deaths on the right. Usually we see cases go up first and then hospitalizations, and then deaths really lag by about a month. It takes a month to die from COVID typically. A couple of weeks of being sick and then being admitted to the hospital, then being on the ventilator for 2 weeks before the death happens. So that's a lagging indicator on the bottom right there, you can see. But you can, get a sense from the cases and hospitalizations that we may be at the peak of this Delta surge. Every surge that we've had is going to have a downside where things start declining. So hopefully we're on the way to there. But it's extremely variable depending on what state that you're in. And so this is the state-by-state breakdown of the case rate per 100,000. The deaths tend to follow the case rates there. But you can see that a lot of the southeastern states, you got West Virginia, Tennessee, Kentucky, South Carolina, Alabama, Montana, Texas, Florida is in there. In terms of those case rates, these are still very, very, very high case rates that are just surprising. California is number 45 out of 50 states here. So we have a lot of population, so we have a lot of cases. But I think this actually speaks to the fact that California officials, despite all the controversy, have done a fairly good job at keeping our population safe, keeping vaccination rates as high as they possibly could be, and really having low numbers. There was one point where we were actually number 50, the lowest numbers of case rates in the country. Of course, that's gone up just a little bit recently, but number 45 out of 50 is not bad. Transmission rates is shown here just on this particular graphic here, and it's just completely regionally different. The blue line on the top left, as well as on the top right, that's just a different time scale, is the southern states. And so the south of our country has just been hit extremely hard. And it's not hard to see why. Mostly, I think this is because of lower vaccination rates in many states, as low as the 30% range in some of the southern states that have been hit the hardest. as well as policies that have really not endorsed mask wearing so much. You can see every couple of days, one state jumps out with its own outbreak, and the latest one is West Virginia that's really having this exponential spread. On the bottom right is the county by county breakdown from the CDC in terms of transmission. And most of the country is in this very, very high. In fact, 93% of the country is in high transmission still. If this were back last year, we would all be locked down based on the colored tiered system. But because our vaccination coverage is relatively good, we don't really have to do that anymore. But you can see places of California starting to emerge from that, including some Southern California counties with dropping down from high to moderate or substantial transmission. In California, they just started reporting cases a little bit differently, and you'll see a lot of graphs that look very similar here. What you see on the top left is the curve of vaccinated cases versus unvaccinated cases, the red being unvaccinated. And again, this is sort of why we say pandemic of the unvaccinated. By far and away, close to 80–90% of the cases we're seeing are in unvaccinated people. In terms of the curves we're seeing in California, it does look like we're getting to the end of the Delta surge in California in terms of confirmed cases, and then going to the right, hospitalizations and ICU patients look like they're flattening off there. The death rate is not as much of a bump as you saw in the rest of the country, but there certainly are people dying in California. A daily average of about 85 people. I just looked this up again, and we're looking at it's up to about 130 deaths per day in California, which is far less than in many other places. Just by reference, Florida is seeing about 360 deaths a day in that country, despite having a much smaller population. Widespread transmission still everywhere in San Diego, except for only a couple little pockets. We're hoping that as we reach the plateau here, things will go down a little bit. We've seen the numbers every day start to go down just a little bit. This is a little bit of an older slide. It only goes up to September 7th. And I will say we had a couple days on the 10th and the 11th with, again, over 1,000 cases in San Diego County. But, not where we were, where consistently every day we had more than 1,000. This is kind of an ongoing slow boil, I would say, of additional cases, with some signs that the numbers are going down, whether it be cases, deaths, or the number of outbreaks. Now, San Diego has started breaking down unvaccinated versus vaccinated cases and hospitalizations and death, just like in many other places. And they've calculated this. What is your increased risk if you're unvaccinated? So you have a 4-fold higher risk of having a case of COVID in our county. That's the orange curve of unvaccinated folks as opposed to the green curve of vaccinated folks, with the blue being the overall average. Same kind of picture in terms of hospitalizations, but even more dramatic. So this goes to the idea that vaccination is not necessarily protecting against infection altogether, but definitely protecting against hospitalization. So the green on the bottom is very, very few people that are vaccinated getting hospitalized, whereas most of the hospitalizations are in those in the orange curve who are unvaccinated. You do the math, and it's a 50-fold higher risk of being hospitalized. And then here's kind of the summary also with deaths, hospitalizations and cases as well. Those that are unvaccinated are not fully vaccinated in blue, and those that are fully vaccinated are in orange. I want to remind everybody that the term fully vaccinated means at least 2 weeks after your second dose. So people that have been on the fence for a long time or are just now getting mandated through their job to be vaccinated, it's going to be 4 to 6 weeks before you're actually protected. So like I said, we've seen many people in our clinics who get the vaccine and a week later they get sick. The vaccine's not really protecting them at all at that point. You have to be at least 2 weeks past the second dose of the vaccine. So in summary here, of the cases in San Diego, 81% since March have been in unvaccinated people, 96.6% of the hospitalizations, and 88.9% of the deaths in people who are unvaccinated. And you might say, well, hey, wait a minute, there's some people that are fully vaccinated that are still dying. And the answer is yes. Some people are in their 80s and 90s and very frail, may not mount a very good response to the vaccine. The vaccine is not 100% foolproof, but suffice to say that it is protective in the majority of cases. One thing I just looked at the county report and just wanted to point this out, which is that when you look at different age groups, clearly the age group of 20 to 39 is responsible for the vast majority of cases that we're seeing. So these are younger people that really don't think that they're at risk. But what's concerning to me is we're actually seeing increases in hospitalizations of patients in this group. This is pretty serious. People in their 20s and 30s getting hospitalized with COVID-19. They may not die and they won't show up in the death statistics at all, but it's they're probably going to have significant sequelae or long-term effects from being that sick. Of course, you can see the deaths really are concentrated in older people. So we have a pandemic that's being perpetuated by younger people that may or may not be vaccinated, and yet the older people are really paying the price in terms of the death numbers there, that spike in blue. Okay, let me get to variants, and I think we're doing okay with time. I'll talk for maybe another 10 minutes or so and then have the rest for questions. So I like to put this graphic up here because people will say, what does a variant actually mean? And I think it's a very simple concept that gets lost with all these crazy numbers and everything, but I want your eyes to start at the bottom left here. You've probably all seen this graphic of the coronavirus with this spikes protein sticking out on the top of it. If you go up, an amplified view of that spike protein is there, where you have the S1 subunit and the S2 subunit. And at the very tip of that spike protein is this receptor binding domain. And there's even a zoomed in picture of that if you go just to the right. So what this is this is the point of contact that the virus uses when it first enters your nose or your mouth or your respiratory epithelium, your respiratory tissues. And it's that receptor binding domain that's reaching out and touching your receptor to sort of lock in there and actually enter into your cells. It's almost like a lock and key situation where the virus is sticking out the key and it has to sort of fit into the lock of that receptor on your lung tissue or on your nose tissue to get in. And all that variants are just slight mutations in that little tip of the key that's trying to reach into your cells. You can see the names of the mutations there with those letters and numbers. Don't worry about that. But really all that makes a one variant different from the other, or alpha versus beta versus delta versus mu, is just a slight change in the way the tip of that protein looks. It doesn't really necessarily change the rest of the virus. It's still COVID is still COVID, but some of the characteristics that we see are just related to how well the virus can enter in those cells. And then we see other things like how much it makes copies of itself and that type of thing. So on the bottom are actually some of the variants that we're used to seeing. B117 is the alpha variant, B1351 is the beta, and then B1617 is the delta. And you see they just have slight differences in the tip of that receptor binding domain. That's really all it is. And these are mutations that happen naturally. They're not caused by the vaccine. That's a misinformation that's out there. The vaccine actually reduces variants. They're caused by people being infected with COVID, who again are largely unvaccinated people. It's been quite remarkable how much the Delta variant, which you can see here as B1617.2, has completely taken over in the United States. So as of September 11th, it makes up 99.4% of the variants that are being sequenced, with another 0.2 and 0.1 of just sub variants of Delta there. So it's completely taken over, mostly because it's just more contagious. Now let's go into a couple of the characteristics that have been observed. I don't necessarily have an explanation as to why all this occurs, and I think scientists are trying to figure it out now. But what's been observed is that people with Delta have 1,000 times more virus in their noses than those with the original Wuhan strain. And what this looks like in the graphics on the bottom here is that the viral load in blue from the original Wuhan is sort of relatively low. Maybe it's equivalent at the very, very beginning, but it sort of falls off really low there. Whereas in the red, the viral load of Delta is just so much higher throughout the entire illness that the person is sick. So much, much more contagious. It kind of shows you exactly the same thing on the right-hand side. We also see a higher viral load that doesn't fall down as fast. And there was a little piece of information from this outbreak in Massachusetts that vaccinated people could have the same level of virus as unvaccinated people. That's in this graphic on the left in blue. But after that, the similarities kind of go away. And what you see on the right-hand side is those that are vaccinated in the green, the levels of COVID or of SARS-CoV-2 in their noses falls off much more quickly compared to those who are unvaccinated. And so it's kind of a different picture. And then on the bottom right, just take my word for it, those who are vaccinated actually have lots of protective antibody that's going to probably make that virus less contagious and less transmissible. We also have seen in terms of infectiousness, remember that people are actually most infectious right before they develop their symptoms on day -1 or -2. But what's been seen is the secondary attack rate, meaning how many people a single person with COVID will infect, clearly higher in the Delta variant as shown in these triangles compared with the ancestral variant or the Alpha on the bottom, which means that you're infecting sort of twice as many people on average with the Delta variant. And then I don't think I have a graphic for this, but what about severity and what about sort of what the illness actually looks like? Well, the time from being exposed to developing symptoms has been shortened to 3.7 days as opposed to more than 5 days. And then the actual risk of being hospitalized, being admitted to the ICU and dying looks like it's at least twice to maybe 3 times as high with Delta compared to other variants. We're not sure exactly why that is. It might just have to do with how much more virus there is in the nose and how much more of a dose, a big dose that you get of the virus. So putting all that together, you may have seen this graphic. This basically looks at a lot of other diseases out there, including the flu and Ebola and smallpox and measles, and tries to show you on the x-axis here how transmissible it is, and on the y-axis here how deadly it is. And basically you've had the original SARS-CoV-2 in pink here. We thought we had a good idea of what COVID actually looked like and what this virus looked like. And there's been a tremendous shift to the right, and you even can look a shift upwards, meaning that it's much more transmissible now that we have the Delta variant and a little bit more deadly in terms of the fatality rate. And you'll see that there's overlap between where the Delta variant is and chickenpox, which is known to be an extremely infectious virus. So really the game has been completely changed by this collection of mutations. So to summarize, we used to think that the R naught, or the number of people a single person would infect, was about 3. Nope, it's now more like 7 to 8. We used to think we could vaccinate our way to herd immunity, and frankly, I don't think that's possible now because of the Delta variant. We used to think you had to be in a room with someone for 15 minutes without a mask on to actually be infected. Now there's been 5-minute or less exposures that result in spread. We used to think we knew who was going to get sickest from COVID-19. Now we're seeing younger and younger people with less comorbidities get sicker. We thought our vaccines were 95%. It looks like now they're in the 70s and 80s. And then we thought our vaccines protected completely against severe cases. That now seems to be slipping a little bit. We used to think our immunity would be long lasting, and now it looks like it's waning away in 6 months. And we also used to think people that were vaccinated had no risk of spreading the virus, and now we know that's not true. People that are vaccinated have less of a risk of spreading than unvaccinated people, but it's not 0. So really tough for people to communicate in a clear way that we really are dealing with a different virus. It's kind of been a game changer, but hopefully I've summarized that for you too. Okay, just a little bit on vaccines, and then I'll finish with how the vaccines relate to the new variants, and then we can stop for questions. So again, I mentioned this is the largest vaccination campaign in the world. We now have vaccinated almost 200 million people that have been fully vaccinated. So again, the word experimental just doesn't really apply. We've been watching this very closely, and we just have so much experience now with these vaccines. Pfizer, 200 million doses, Moderna, 150 million doses, and J&J about 15 million doses. And you can see the population breakdown. Those that are older have a much higher vaccination rate. 82% of those above age 65 have been protected. I think it's because they realize that their risk of dying is really much higher. But when you get to the overall national population, it's only 54% of Americans that have been vaccinated. And although we kind of charged out quickly in the beginning, we're now the lowest vaccination rate of industrialized countries in this sort of G7 group. So many other places, including Canada and Europe, have really gone beyond us. And that's really because of misinformation, I think, and vaccine hesitancy. Just one quick note about vaccination and pregnancy. I understand that people who are pregnant are leery of taking a medicine or a vaccine, but there's now enough safety data that we know vaccines are safe in pregnancy. We know that they are not causing any increased risk of stillbirth or miscarriage. They're not related to infertility. This is really one of the toughest myths out there to bust, but it's absolutely not true. I'm not going to show you all the data, but CDC has been collecting data on thousands of pregnant women that have been vaccinated. There is no increased risk of miscarriage or early child delivery, such to the point where the American College of OBGYNs has strongly recommended vaccination for pregnant women. This is also because it has been recognized that COVID-19 is much more severe in pregnant women and causing death rates 20 times those in comparable women who are not pregnant. So you've probably heard a lot of the tragic stories of women intubated or dying or having to have C-sections while they're on a ventilator. And then that family does not have a mother. It's happening all over the South, and it's really, really tragic. I actually think there's a woman in Southern California who left 5 children, and she was relatively young. So very, very serious. The rate of vaccination in pregnant women is only in about 25% range. So that really, really bothers me that there's a lot of women that could have severe bad outcomes. Now let's talk about vaccines in variants and whether they're still working. So this is a complicated area. The FDA is actually deliberating today their expert committee about whether booster doses are necessary. And let me just try to summarize kind of what the deal is here. This is a very carefully done study from New York where they looked at the effectiveness of the vaccine against getting a case of COVID at all. That's the first one here in the middle, or the effectiveness against preventing hospitalization of getting vaccinated. And they went from May all the way through July, which is exactly the time that the Delta variant started coming. So you can see the estimated vaccine effectiveness from getting COVID at all did significantly drop from 91% down to 79%. So we're seeing, a good 10 to maybe 15% reduction in effectiveness at stopping the infection altogether. However, even those people that had quote unquote breakthrough cases had still a very, very low risk of getting hospitalized. And you can see the effectiveness against hospitalization stayed very strong in this study at 95%, whether it was May or July after the Delta variant has come. So the arguments that are going on at the FDA now is, do we need a booster dose to get that prevention of infection way up back to 90%? Do we really need that? Or are the vaccines working well enough and preventing hospitalizations out there? CDC is looking at this, and the graphics I showed you from San Diego are clear across the country. I'm going to show you a whole bunch right now that the rates of hospitalization, the rates of cases, and the rates of deaths in vaccinated people are still extremely low. This difference between the black line and the blue line is essentially the effectiveness of the vaccines. And you can see all the hospitalizations going way up in July, the deaths going up, and then really not budging that much in vaccinated people. So it shows that the vaccine effectiveness may be declining a little bit for getting COVID at all, but it's still very effective at preventing hospitalization and death. And I'm just going to run through, this is my colleague sent me this from Seattle, King County, showing that the hospitalization rate in dark blue here is much, much, much higher in unvaccinated people and barely perceptible in those that are vaccinated. So you have a 50-fold less risk of getting hospitalized if you've been vaccinated. On the right-hand side is data from West Virginia that's now having a tremendous outbreak of cases and deaths in people mostly that are unvaccinated. And we have hospitals showing these types of graphics saying that out of 162 people right now at the University of Alabama that are admitted with COVID, 145 of them are not vaccinated. And almost nobody goes on to be in the ICU or ventilated or die if they've been vaccinated. Here's a chart just showing vaccine effectiveness. The one outlier here seems to be Israel. So Israel, as you probably know, did only Pfizer vaccines, and they vaccinated very aggressively through their whole population. They are showing some decrease in effectiveness of vaccines, but not so much in severe disease. What we're now seeing is just a little bit more of that declining in terms of protecting against severe disease. And that's the discussion right now at the FDA in terms of certain populations, such as those who are older, whether they need to get a booster to still be protected. Some scientists have come out in opposition to this, saying that the vaccines continue to be effective against severe disease, including that caused by the Delta variant. And a provocative statement here that's actually kind of more of an ethical dilemma that says that current vaccine supplies could save more lives if used in previously unvaccinated populations than if used as boosters. So the debate rages on. I'm not going to solve it here, but just today, just this morning, I copied these pictures just this morning. I'm not going to go through these because it's kind of getting late. But this is provocative data from Israel, where you can actually see on the right-hand side here that if you are to give a booster, what happens? Well, you increase the titer of antibodies by quite a bit, especially in those that are 65 to 85 years of age. You can see the levels of antibodies going down, and then a booster brings them way back up. This is provocative. It shows that boosters probably work, but we're just not sure that they're necessary, because it's actually normal after you get an infection or a vaccination for those levels to go down. You might have heard on the radio this morning that, if all of our antibody levels for everything we've ever encountered remain super high, our blood would turn into sludge. We just can't do that. We have to actually have memory from the infections, which is in the form of B cells that can be sort of reactivated at the time when you encounter that virus again. It doesn't mean it's going to fully protect you from getting COVID in the future, but it is going to certainly do what it's supposed to do and prevent you from getting really sick. So here's, I think, one of my final slides here, is a summary of the Public Health England approach to this. And what you can see on the top left is AstraZeneca, on the top right is Pfizer, and on the bottom is the Moderna. And what you see is sort of a slight decline in vaccine effectiveness as you get further and further along. We have less information on Moderna because they weren't using it for that long there. But you do see with the Pfizer and with the AstraZeneca in the Delta variant cases in orange here, a little bit of a decline in effectiveness as we go through time. And then one other update into the Pfizer effectiveness, just showing that we're still doing pretty darn good, that those curves between those that got placebo and the Pfizer vaccine are still very, very much different from each other. This long-term study of the original trial for Pfizer still shows about a 90% effectiveness of the vaccine. So what are we going to see? I think we're probably going to see what is going on in the UK right now, which is that we're going to probably recommend boosters for certain groups of people. And the JCVI is the group in the United Kingdom that has recommended that boosters be given to people in nursing homes, those that are above age 50, those that are frontline healthcare workers like me that are exposed every day to people with COVID, and then those with underlying medical conditions or those who care for people who are immunosuppressed. We will know in the next week or two about this, and then have recommendations. One of you asked in the question, when are we going to start giving boosters? I can tell you there are people that are going out to pharmacies now and lying about their vaccine status and getting a third dose. We will actually have more of a solid recommendation based on data just in the next week or two. This is just what CDC says might happen. There's nothing that's in stone here, but they're saying long-term care facility residents such as nursing homes, healthcare personnel, and then they threw out age 65 or above. We'll sort of see what kind of cutoff they use going forward. All right, Charlie, so I'm going to maybe toss it back to you for the Q&A.
Okay. All right. Okay. Thank you so much, Dr. Ramers. We're going to hop into some Q&A really quick. And Dr. Ramers, before we move forward, we just got breaking news from the Hill. The FDA panel voted against COVID-19 boosters for those ages 18 or 16 and above, but indicated that they'd be open for boosters for the elderly. That just happened while you were speaking.
Great. Let me just clarify that committee was called the VERB PAC, and that's an advisory committee that advises the FDA. The FDA still is allowed to go on and make their own kind of decisions about that. But that kind of is in line with what I showed you, that for the general population, we probably don't need them, but for older people, yes.
All right, so Dr. Ramers, we have a few different categories of questions. We've kind of lumped them together. The first category is on COVID transmission. Can you explain, I know we've covered this pretty in depth so far, but maybe let's hop to the second question. Is it safe to travel? Is it safe to travel by train or by plane?
Yeah, this is a hard one to answer because it's a complicated situation. Going on a plane ride for 3 hours is not just your time in the plane, it's your time on the Uber ride there and your time in an airport with thousands of people who may or may not be wearing masks. I think trains themselves are relatively safe. They have really good ventilation. So they have HEPA filters. The air in a plane actually comes down, which is good to get those aerosols from lingering in the air. And if you have policies where people are actually wearing masks, and the airlines have been quite good about this, you're generally protected. The problem is not everybody wears their mask properly, and you have people that are eating on the plane and drinking, of course, pulling the masks down. So in the plane, I'm not actually that worried about. I would suggest you get the best mask you can get your hands on when you're traveling, either a surgical mask, which would be like these ones here, or an N95 or an N90 if you can. But what's more risky is you're on your way to the airport, because just think of the number of people you come in contact with and the number of people you share the air with in a large airport terminal. I think it's Terminal 2 in San Diego. It still feels very crowded to me walking through that space with people that are just packed in like sardines there. That is the risky time. And of course, people are eating and drinking there as well, pulling their masks down. So I think you can do it if you are very disciplined, and you have to be close to perfect. Look, I don't pull my mask down when I'm in clinic around COVID-19 patients, and nor should you when you're in a situation like that. So yes, I think we can travel. Being vaccinated, of course, is a very good protection against getting infected or getting severe disease, but it's not without risk completely.
Okay, thank you. We're going to move on to the Delta variant section. Dr. Ramers, do we know any of the long-term impacts within the scientific and provider community of the Delta variant?
Yeah, I don't think that they're going to be that different from just regular COVID. So like I said, these variants are defined just by a difference in the spike protein at that very tip, and it has a lot more to do with infectiousness and causing more infections. But COVID is still COVID. And I appreciate the question, because the long-term impacts of COVID itself are definitely not known. We keep seeing more and more studies come out identifying the syndrome called long COVID in a significant proportion of people. So the going estimate is about 10 to 20 or 10 to 30% of people will have COVID symptoms that last more than a month after they should be recovered from COVID. A CDC study just came out I think I had a slide on it, but I skipped it in the end, that 30% of people still had symptoms at the 2-month mark. Okay, and these are most commonly fatigue and trouble breathing, still with loss of taste and smell. I mean, with so many infections that we've had, we're going to have hundreds of thousands of people that have long-term effects from COVID. So I don't think the impacts are fully known. Now, the NIH has given a $1.2 billion research program to try to develop cohorts, to look into the science behind this, to try to figure out what is actually going on. Is it leftover virus? Is it an inflammatory response or an immune response? But suffice to say, this is a huge problem. I don't think it's really specific about Delta, other than the fact that more people will be infected because Delta is so contagious.
Okay. Dr. Ramos, has the Delta variant taught scientists anything new concerning about mutations of the virus of SARS-CoV-2? But I'll kind of add on to this, but in studying viruses altogether, what have we learned since the pandemic?
You know, I don't think there's been too many surprises. There's lots of people that have been studying viruses, and other viruses actually mutate at a much, much faster rate than coronavirus. So like influenza, you know, every single year seems to come out with a completely different version. And my patients that have HIV, their virus can develop resistance and mutations at a much, much faster rate than coronavirus. But I think it does tell us that as long as there is ongoing infection, and as long as there's a pool of people that are getting ongoing infection, there will be ongoing mutations. And what we're all kind of worried about is a mutant coming along that really evades the immune system. The newest variant that we see is the one called mu. That's a variant of concern, and it does show reduced susceptibility to vaccine-induced protection as well as natural immunity. So everybody likes to say natural immunity is the best and you can't get better than that. Well, in terms of the mu variant, natural immunity doesn't really protect you all that much. So that's the concern. I don't think that's anything new. We've sort of known this with every other pandemic and lots of other viruses.
Okay. I'm seeing a few questions kind of discussing the Delta variant in children. One of the questions I just want to pull really quickly here is, how much is the effect of the Delta variant on kids' ages between 14 years old and less?
Yeah, I'm going to answer this kind of in the same way, which is to say that COVID is still COVID. The Delta variant, what that adds is it just adds a little bit more infectiousness. So COVID, we know what the effects are in kids, which is that most kids recover and they do fine, but not all of them. And that the long-term effect of COVID, the so-called long COVID, also does happen in kids. And that some kids get sick enough to be hospitalized. Like I said, 18,000 hospitalizations in the country, over 500 deaths. It really bothers me when people say, oh, well, those are just kids with underlying conditions. You know what those underlying conditions were? Being overweight and asthma in over 60% of those kids who have died or who've been hospitalized. Those are extremely common health problems in children. So it's not like these are medically fragile kids. These are kids who are just a little bit overweight or who have asthma, a very common condition. So I would say that COVID itself is mostly benign in kids, but not everybody. So they are at low risk, but not no risk of having complications. And what Delta adds to that is just an increased contagiousness or an increased attack rate.
Okay, thank you. We're going to move on to pediatrics. I know we've, just briefly discussed this, but just to reiterate it, because I'm even seeing a lot of, comments and questions coming through the chat. What's the best way to protect children in our community and our own children?
I have a couple of things. So it's not just one thing. First of all, that example I showed you from Marin County hopefully shows you that even if you're doing 2 or 3 things and you're not doing all of them, you can still have outbreaks. Most importantly is to have the adults around those children to be vaccinated. And this is a case where, unfortunately, in the South, we've heard a lot of news about children's hospitals getting much busier with COVID admissions in kids. That is 4 times likelier in states with low vaccination rates in the general population. So there is a direct relationship between the number of adults that are vaccinated versus how many kids are getting infected. But it's not just that one thing. Of course, vaccines themselves can only do so much. We also have to worry about masks and ventilation and all that type of stuff. So in order to protect your kid, especially if they're young and can't get vaccinated, if they're less than age 12, you need to teach them how to wear a mask properly. You need to look into what the policies are at your school. And thankfully, in the state of California, a lot of this is kind of coming down as state mandates to get staff and teachers vaccinated and to have mask wearing be mandatory. In terms of balancing the risks and the benefits of masks, sure, we don't want to have to wear masks forever, and people like seeing each other's faces, but there's just no evidence that masks are harmful for kids. This idea that masks are causing a whole bunch of bad tooth problems and bacteria and facial infections. I mean, if that was true, I've been wearing a mask for 8 hours a day for the last 2 years, and I haven't really had any of those issues. And every surgeon that's ever done a surgery in the US has done that as well. So on the balance, vaccination, making sure ventilation is really good. And something that gets overlooked is not sending kids into school if they're sick, making sure you have access to really good testing. That's going to be another really key element of this. And adding all those overlapping things together, we can have safe in-person school, which is the goal that everybody should be able to agree upon.
Okay, and for the second question here, this is kind of a unique question we got from the audience. We have someone who is prescribed a very strong suppressant and is wondering, okay, should I still get my booster? What should I do first? How would you respond to this person?
Yeah, there's a kind of a clinical case scenario here. So first of all, Imuran is an immunosuppressive drug. We think that there's about, I think, 10 million people in the US that are on immunosuppressive drugs and don't have normal immune systems. And they've been depending on the rest of us to get vaccinated to protect them, to be honest. And currently, as of right now, the FDA and the CDC have approved a booster dose for immunosuppressed people. So this person is in fact eligible to get a booster dose. There is some specific advice from the American College of Rheumatology about lowering doses or pausing doses of immunosuppressants prior to getting a vaccine. So I actually agree that yes, you should probably wait on that Imuran until getting a vaccine and then start it later on.
Okay, great, thank you. We're going to dive into vaccine and boosters really quick. First question, where is San Diego with providing booster vaccines for the community? Is the FDA going to approve soon? And are there plans to keep going forward to inform the community?
Boy, I'm going to do everything I can to keep informing the community. You'll probably see me on the news talking about this as soon as the FDA rules on this. Right now, we feel like we have a pretty good infrastructure to deliver vaccines. You can go to your own doctor, you can go to a pharmacy to get vaccines. They're out there. We're not in the place we were last year where they were in such short supply. They're just not formally approved yet. So like I mentioned, don't go ahead and get a third dose if it hasn't really been authorized. We have scientists, we have the FDA and the CDC looking at this, not only in terms of effectiveness, but in terms of safety. We don't want to give third doses to everybody when there's actually a safety concern. So trust me, it will come very, very soon. This advisory committee was meeting today. The CDC will be meeting next week. And then you'll hear all about it in terms of booster doses. And I would say all of the places that you got your primary vaccine, you should probably just go back to where it was to get your booster. If that was a superstation in Petco Park, then maybe you'll have to find a different place, but there really should be plenty of venues to get the booster dose.
Thank you. Dr. Reimers, you've done a really good job of showing all the data and making a pretty clear, I would say, great argument for getting the vaccine. But in layman's terms, if someone were to ask you, hey, I'm seeing people who are vaccinated, who are still getting infected and getting sick. So then what's the point? What would you say to them?
Yeah, the point is that the vaccine is not going to be a magical force field that prevents you from getting infected altogether, but it absolutely will prevent you from having a more severe case. So I think that's a misinterpretation of what's going on. Yes, breakthrough infections are actually happening, but when you think about the biology of what's happening, a vaccine is not going to protect a virus from getting into your nose. That's just going to happen based on who you're around and if somebody coughs on you. But it sure can work as soon as that virus gets into your body. And it might be that you develop cold symptoms and get sick for 4 or 5 days, but you don't go into the hospital. That is really what vaccines are doing. And hopefully all the charts, I showed you 15 different charts showing exactly the same thing, that your risk of being hospitalized if you're unvaccinated is way higher, like 50 times higher than those that are vaccinated.
Yeah, thank you. So, I think everybody's heard this before. A lot of people thought that the vaccines that have come out had part of the SARS-CoV-2 virus within them. Can you explain what's in these vaccines and how they work?
Yeah, I think this is a concern about the mRNA vaccines, the Pfizer and the Moderna. So it's really a new technology, relatively new. I mean, they've been working on it for 10 to 15 years, so it's not all that new. But it's a way to actually train the immune system to develop responses against certain proteins in a very ingenious way, I would say. So the mRNA is the little piece of very, very fragile genetic material. It's wrapped into a lipid particle. And if that sounds scary to you, lipid particles have been used in infectious disease treatment and cancer treatment for decades. We use it in a lot of medicines that we use in order to deliver things. And it just delivers a message so that your immune system can respond to that message. And then the message disappears completely. It's like a Snapchat message. It's really ingenious that that goes away right away. So this technology, I guarantee you, will be actually useful to us for many, many other diseases going forward. Moderna is already starting to work on a flu vaccine and an HIV vaccine and all these other things that can really help us. And that's about it. There's those two components, and then there's preservatives and salts, and that's about it. There's no microchips. There's no toxins. People have said that, well, you're injecting toxins in people. No, actually a tetanus vaccine has a toxin in it, or when you get Botox, that has a real toxin in it. This is just the mRNA instructions that are literally gone within days after getting the vaccine.
Okay, and I know we're pretty close to running out of time here, but we get this all the time. Dr. Ramers, one of the things that we're hearing is, how were we able to create a vaccine so quickly? And it's raising doubts about its legitimacy and efficacy. How can I trust the safety of these vaccines when they were made, so rapidly?
So I'll say this very simply. We're able to make it so quickly for a number of very favorable reasons. Number one, the government threw $9 billion at this, and it allowed companies to address this with all of their might, all of their power, all of their scientists. That really accelerated things. Number two, the technology that was used had been studied since the original SARS outbreak, which was 15 to 20 years ago, and had been tried in many other vaccine candidates. So it was all ready to go. Number three, there's been amazing collaboration between scientists. It was 60 days from the time that the sequence was first published in China to the time that a vaccine made it into somebody's arm in clinical trials. And number four, all of the steps that are normally taken in getting a vaccine approved for full FDA approval were all taken in exactly the same way, except some of them were just overlapping. So phase 1, phase 2, and phase 3 trials happened at the same time rather than doing them one after the other. And then finally, how can you trust if they're safe? This has been the most studied vaccine in the history of the world. And we have incredible registries that have been picking up these incredibly rare side effects like blood clots and like myocarditis. And those types of things, which occur at like 1 in 500,000 or 1 in 1,000,000 people. Those aren't going to show up in clinical trials, but they've shown up in our follow-up studies. These risks are just real, and we have to identify them, and they're still much, much less than what the COVID virus is actually doing to people in terms of getting sick from it.
Okay, thank you. We have a whole other section here, but we're just going to, try to be very quick. Using your experience and knowledge and perhaps a little crystal ball, where do you see our relationship with COVID and all its potential variants in 1 year, in 5 years, and 10 years, in terms of health policies, regulations, regarding vaccinations, masks, alternative treatments, and then any other elements that you feel will become important as you look ahead?
Boy, that's a lot there. But I think in the short-term future, what we're seeing is going to continue. And that is that vaccinated people will have mild disease. Unvaccinated people will continue to die. So we're going to basically split into two general populations. COVID viruses, or coronaviruses, I should say, generally are cold viruses that are quite mild. And if the more population develops immunity through being infected or through being vaccinated, we may reach a point that this sort of becomes a mild thing. The way the flu is, where we don't have to shut down whole societies because of the flu every year, that we can just go forward and do that. In terms of other future developments, I think we're going to continue tweaking our vaccines, our schemes, whether we have boosters, whether we use them at different intervals, and we'll just follow the science and see what works the best. We are likely to have actual treatments that work instead of things that really don't work that are out there. There's antivirals that are being developed right now. So I think more and more this is going to become more routine, like the way flu is in our society. And I don't think we're going to need lockdowns, really precisely because of the incredible efficacy of the vaccines that we've had so far.
Okay, thank you so much. I know we're out of time here. So Dr. Ramers, I want to thank you so much for your time. We appreciate sharing all of your experience and knowledge and all those stories with us. I want to take an opportunity right now to thank our sponsors one more time. Thank you to everybody who has supported us in the last year, to all of our partners. We appreciate your help and your willingness to give back to the community. And we are going to be back next November, Friday the 12th. We're going to be featuring featuring Dr. Joseph Sepulveda on the opioid epidemic. Please join us then. And until then, everybody, please stay safe. Thank you so much for being part of this webinar, and have a good day. Thank you.